I'm going to start out with a public question, which is from Bonnie Harris at Howard to Mark. Could you restate what? Okay. The person was asking about the top 10 CDC items. So just if you could remind people where those, where you could get those 10 public health functions at.
Sure, of course. The CDC publishes those on their website, and they're in several languages, et cetera. But if you just Google for the 10 essential public health services, you will find that lovely document. And there's several tiers of presentation. I'm sure you'll enjoy it as you're falling asleep some evening.
Thank you. I have a question starting off with Raina. Earlier we heard, your work is so exciting, and earlier we heard from Renu, who is very involved with the Recover initiative, which a lot of that is really pulling from electronic health records. And I'm really, much of what you have been presenting could perhaps be construed as some citizen science approaches. And I wonder if you could just talk a little bit about how you might see some of those different approaches coming together to advance diagnostic excellence, not only initially for COVID, but particularly for post-acute COVID syndrome as well.
Yeah, thanks so much for that question. I think there are a lot of opportunities to collect data from structured and unstructured data sources, and those that are traditional and less traditional. I think some of the advantages of the more traditional approaches is that they often tend to come from more validated data sources, more nationally representative samples. And so we have a little bit more of an understanding of the validity of those data sources. When we expand to think about posts on social media or online searches or information from sensors, we have the trade-off of having exponentially more volume sometimes, but we lose some of that potential validity. I think the advantages are in the real-timeness of data from some of these social media or other sources, and that if we were to rely on a survey, as we all know, sometimes the data won't be available for years. But if we wanted to really do more precision-based messaging or respond to the questions that the public has, then being able to both harness these data sources to understand what are the things that people are most concerned about, be responsive to those in very targeted ways, and then also have a comprehensive strategy where information is disseminated through both traditional sources and also using some of those more the social media resources where the information may be a little more interactive. It will be potentially more current. It can happen faster. You can have streams of information, and we'll have some be a little bit more dynamic. But there are these trade-offs with the accuracy that come with the volume. And so I think we need both. I think we need to get better at collecting this data from these non-traditional, I guess they're not non-traditional anymore, but from these more social media and other sensor sources for public health. And we need to be able to mirror that with the more traditional data. And that's somewhat of the space where I like to exist, because I think there are just huge untapped opportunities in these emerging data sources.
Yeah, Mark, as someone who's been on both the public health side and now the EHR side, what are your thoughts about maybe some of the important standards and ongoing efforts? You mentioned the ONC report and other kinds of things for possibly thinking about the integration of novel data sources along with some more traditional sources to advance diagnostic excellence and also surveillance.
Yeah, so there's the messaging standards and terminology standards, I think we got to be careful not to create too many variants and foci, right? It gets too hard for everybody to manage and maintain them. And I think public health is part of a healthcare ecosystem, and the same, whether it's fire and so on, standards need to be able to serve our public health needs as well as our I'll call routine clinical care needs. When we think about some of these emerging or as you say, Renaud, they're not necessarily new anymore. They've been around for years. Sorts of data. The question becomes, what are you going to do with them, and how are you going to address them? I think, are you trying to link things into individuals, or are you doing things at a population level, and so on? So I think that there's a whole suite of work that we probably have to think about that's related to, I think about it's data about our communities, the place where people are living. And we have emerging items in that direction in terms of, for example, social needs data. We're creating better ways to represent and manage that at a population or geographic sorts of levels. So terminologies, I think we're in not bad shape in these things. I think some of the concepts that are being constructed and emerging from the work that folks on this workshop and other are doing, obviously there's always a sort of process and lag getting those incorporated into standard terminologies, but there's good pathways for that. And I think the structures for messaging and carrying the data are probably adequate at the individual level. So I think that the community level is where we really have work to do.
Okay, thanks. I wanted to go to a question for Martin. Someone from the public had asked, one, whether or not there was any progress in contact tracing in the UK. But I was also interested, since there was such, I was just curious about your opinion. There was such high adherence to other types of guidelines, such as mask wearing and people being very testing very frequently. What do you think was different about contact tracing that made it less likely for people to do it, or was it perhaps just not easy for them to do it?
Oh, it was because it was basically chaotic. So you need to put this in the context of the governments over the last decade in the UK, where the solution to any problem has been to go to one of the major outsourcing companies. And I mean, we saw this happen, for example, with security at the 2012 Olympics, when they went to one of the larger security companies and they made a complete mess of it and they had to bring the army in. And we actually had a reversal of that whenever, because it took time to get the contracts done, they had the army running the mobile testing plans, centers, and they were working really well. And they were replaced by the same company that had made a mess at the Olympics, and it made a mess again. So I think that's there is a lot of expertise in contact tracing in the UK and local public health teams, in tuberculosis clinics, sexual health clinics, and so on. And I think we all, on a call like this, will recognize how the contact tracing is a highly skilled task. If you're trying to understand who got a sexually transmitted infection from whom, you have to have a degree of diplomatic skills that are not easily found. But when these large companies went to them, they basically ran it rather like by using a telephone system. So somebody would phone you up and then try to find out where you'd been, and they were doing it with a checklist. And these were people who no doubt were very highly motivated, but they were normally doing things like direct sales or chasing up debt or something like that. And clearly they were not the right people at all. And, these companies were scrambling to get people. The local teams were completely marginalized in all of this. And this is partly a result of the very over-centralized system. But it is this ideological view that if you've got a problem, you go to one of these big companies, including some of the big accountancy companies, even though they have no expertise in these areas whatsoever. And as a result, it just did not work. And was really, really problematic. So people would be called up and asked questions that had indicated that the individuals had no knowledge whatsoever of the local context and so on. So it was I think the other thing I should say is that the procurement that was involved in all of this has been very problematic. There's been a huge issue with government procurement, with the government trying to purchase all sorts of things from personal protective equipment to tests and to all sorts of other things. And unfortunately, because there was a lot of money to be spent in a very short time, there were a lot of people who were taking advantage of that. There are a series of judicial reviews where the government is being challenged in the courts and is consistently losing because of money being given to companies that only existed a week earlier but had links to politicians. Now, the word corruption obviously is one that people are hesitant to use, but I think many people would agree that much of what happened falls within that. So I think that it's a political failure, but the science has been, I think, rather good in the UK.
Thank you. One of the things that a number of people have already hinted at is there might be some, there are inefficiencies, it sounds, in the public health, no doubt, in the public health infrastructures in both countries. Mark particularly mentioned at the policy level, and Martin and Raina might also have an opinion on this, but what would be the important things at the policy level that we need to address to make the public health infrastructure for surveillance and diagnosis more efficient and, I guess, of higher quality as well?
I think one of the biggest challenges that in the US that we have to think about is the fact that we have, and Martin, you talked about this in the UK, the 4 countries each own public health. In the US, it's the local area, the county or the territory that is accountable for public health. And then that rolls up to states and that rolls up to national. And there are policies, procedures, and regulations that cause that to be slow and difficult. And I think that's one of the biggest challenges, in addition to sustained support, that we have to sort through in the US. How can we make that less cumbersome while still retaining, which is very much cherished, states and local rights?
Okay. Any other?
I'd like to pick up on that, if I may. One of the points that was made in the earlier presentations was the importance of co-production and co-creation. And we're with a colleague where we're looking at maybe doing a book which is going to have maybe a working title, Why Didn't They Just Ask? Because as we go through all the things that didn't work in the UK, and many things did, the science I think was very good, but many things didn't work. And it was almost always because whoever was making the decision in Whitehall didn't talk to people on the ground. They didn't listen to the frontline workers in education or in health, or public health, or hospitals, or wherever. Now, there is a famous quotation in the 1950s. A British cabinet minister said, "The man in Whitehall," gendered nature of the language, "the man in Whitehall really does know best." And that was the attitude that, the people on the Hill or in Whitehall or wherever are the ones that know what's good for ordinary people. And of course, we clearly know that that's not the case. But I think that's been the biggest single failing of issuing instructions or policies that didn't actually connect with the lived reality of people's lives. That would have made a big difference. And I think that is all about public health connecting with the communities that they serve and making sure that the information is flowing upwards to the centre as well as downwards from it.
Yeah, to build on, sorry.
No, please go.
Yeah, I was going to say just to build on that in terms of thinking about policy levers. And I think one of the real opportunities is in thinking about what are the policies that should be in place now that will enable us to be in a better position for either the next wave of the pandemic or the next pandemic. And so I think the policy preparedness piece is really important in thinking about how will we set up both resources. This was mentioned before around how public health is traditionally under-resourced, but how do we assure sort of allocation of resources to make our public health infrastructure more robust and able to stand up in cases of pandemic or any public health emergency? And how do we establish policies that will be forward-thinking for the next event that put us in a much better position to be more responsive, to build more resilience in communities, and to strengthen our research infrastructure, our data infrastructure, so that there's less of this reinventing the wheel, putting out fires, but that we should establish that sort of the policies and the in place now that really sort of help us for the next and the inevitable future events.
Could I jump in on that just to say that we've been thinking a lot about this in the Pan-European Commission on Health and Sustainable Development. It was chaired by Mario Monti, a former Italian Prime Minister and European Commissioner. I chaired the Scientific Advisory Board, and also I wrote the evidence review for it. And that was, although it was about health, the commissioners, my fellow commissioners, were virtually all from outside health, with 3 former presidents, 2 former prime ministers, central bank governors, and so on. And much of what we've written in our in the report and the evidence review is about creating the conditions by which finance ministers and others and the international financial institutions will see the importance of investing in public health and pandemic preparedness. Now, we're taking that forward in work with OECD and WHO, and also our proposal for something modelled on the Financial Stability Board, which was introduced after the global financial crisis, is now being taken forward by a task force in the G20. So I think maybe have a look, people are interested at that, because that's about addressing these sort of getting up to a higher level and saying, how can we create the conditions by which health ministers will be helped to do these things, that have finance ministers and heads of government will see the importance and therefore support them. Because there's no point in saying to health, Secretary of Health and Human Services or our health minister, do this. They would love to do these things, but they come up across all sorts of other problems. Of course, you have another problem in West Virginia and Arizona that we don't have, but generally there is, it's about changing that narrative, and that's what we've written about. So please do have a look.
Yeah, thank you for that. I want to turn this in a slightly different direction now. And so some of the information, much of the information that Raina showed really described like that there were major issues with misinformation and disinformation. And so we think about that. It could be for many different reasons. Some of it could be related to issues around health literacy and that kind of thing. So I'm really curious about kind of and I guess this fits back into Raina's precision public health messaging as well, because I think of, yes, around the world, the WHO says it's infodemic, and yet in the UK, you have, virtually everyone being willing to home test and apparently having the skills to do that. So I'm just kind of wondering how that plays out in really ensuring adequate literacy of the public to be able to enact both the testing, the follow-up that would lead us to diagnostic excellence. So maybe Martin and Raina both want to take that on.
Yeah, I think I wouldn't like to give the impression that it's completely perfect. We do have anti-vaccine movements and anti-mask. I mean, they're a very small minority, but they're very vocal. And of course, they're very well connected. And that's where we do have a very strong transatlantic divide, because we know that the communication is very much between the US and this very small fringe group in the UK. And certainly some of the money that seems to be supporting our group seems to be coming from your side of the Atlantic, although it's very difficult to elucidate all of these links. But what we have got a lot of work going on, which is looking at the networks between these people. And obviously with social media, you can make the connections very well. We were very fortunate that with one of the groups that was communicating on WhatsApp, somebody did actually infiltrate them, and there's been a large download of their internal WhatsApp communications, and that will be featured in a paper that hopefully will be coming out in the British Medical Journal in due course. And but I probably better say no more about that just at this point.
How about Raina? Do you want to chime in on this, and maybe from the perspective of not only what you've discovered, but also is there any way that you're using what you've just discovered in terms of misinformation and disinformation into your precision messaging?
Yeah, I mean, I consider misinformation to be a public health crisis, and that this has played out this has played out on such a national, international stage with regard to this pandemic, in terms of the ways in which inaccurate information has shaped so much of public opinion and behavior. There are a lot of different approaches to addressing misinformation, and I think I kind of glossed over that in the slides when I presented. But one approach is you have to find it. Sometimes it's easier and sometimes it's more subtle. There are approaches which have looked at replacing it. That's a little like boiling the ocean, because there's just so much of it, and you replace it and then it's immediately replaced with something else. I think labeling it is important, and that also has limitations. There is a role for really listening and learning from it. And that, just trying to get rid of all of it misses this opportunity to understand sometimes what the misconceptions are and where people are sort of getting, there's confusion around the science. And I think there's a lot of opportunity to really sort of be better public health stewards by trying to meet people sometimes where they are, understand what their concerns are, and then use that as a starting point for a conversation. If I switch hats to my provider hat as an emergency medicine provider and physician, I do a lot of that. Instead of why haven't you gotten the vaccine? Tell me what your concerns are. I want to understand and listen to people. As opposed to labeling, people's concerns as misinformation. But, I think there is a real role for listening, removing it. And then I think there's an opportunity for working with some of the technology companies through which this information is propagated. And there's been a lot of discussion about that. But, thinking about their role in helping to remove, dispel, label some of that information. But most importantly, that's just a long list of approaches. We need science here to understand what works and what's most effective for addressing misinformation. I don't think there's a one-size-fits-all approach here, but I think this is a ripe area for really rigorous sort of science and studies that are going to look at sort of what happens when we, change information on this platform, or when we remove, label, report, et cetera. And that's been an area that I think is pretty exciting, is in how do we study what actually works for addressing misinformation?
I wonder, can I just jump in again on that,
please.
just to say, very briefly, to say we need to also understand the motivations, because there are the people who are spreading disinformation because they have a view about vaccinations or whatever. But and of course, much of the disinformation is coming about, or has been in the past, and less so at the minute, because one of the countries involved is itself trying to get its vaccination rates up, spreading information because it's about sowing distrust in democratic institutions in other countries. You've seen that, we've seen that very clearly. So that's one reason. The other thing is that we know that this disinformation spreads much faster. We published a systematic review on disinformation in health about 2 years ago. And we know that it spreads much faster, so it's being used for spreading malware. and for clickbait, because you can monetize some of the sources. So that's different from the people who are spreading disinformation because they have a view. And sometimes it comes together. There's an operation that was run that was related to your 2016 election out of Macedonia. And whether that was a state actor or whether people were monetizing the website, we still don't know. And it was probably a combination of both. So it's quite challenging to try to disentangle all of it.
Yes, thank you so much. I just want to mention that the National Academies do have a initiative called Based on Science, and with some public facing materials, and the sources of the topics, many of them come from Google searches with data that Google has provided through a collaboration, so that they try to address the most common, some of those common myths and misinformation. And I will put a link on that into the chat. But now this session has, it's time for our session to end. So I thank everyone in the session for doing just an amazing job. And we want to move to the next panel, which will be moderated by Amesh Aldagia and Nicole Laurie. So once again, thank you, everyone.